Hello, everyone. Hi. Hi, friends. Cool. All right. Welcome to Searchlight, everyone. Hi. My name is Janae. I'm going to be your host for the evening. During the day, I am a tour guide here at Eastern State. I see some familiar faces, so thank you for coming back. Everyone who is here for the first time, welcome. We have a great presentation set forward for you. Before we get started, though, I'm going to give a brief overview of our history and some of the programming that we do here during the day. All right. So in 1829, Eastern State opens in the outskirts of the city on a cherry orchard. And it opens with this belief that separate confinement or solitary confinement, as we think of it today, was the main form of rehabilitation. It was the key. They would combine solitary confinement with work and religion as well. This idea prompted the radial plan, of which we are sitting in the central surveillance hub. Surrounding us behind these doors are the spokes or the cell blocks of the prison, right? And this radial plan allowed for both men, women, and children to all be housed separately together while encouraging penitence through isolation. This radial plan has been replicated around the world over 300 times. We can see some examples here. It was also replicated online. Not photographed here are the schools, hospitals, airports, and even dog kennels that also use the same radial plan design as well. But the legacy of Eastern State extends beyond its architecture. When we think about the lives that were impacted here, it's over 80,000 people that were incarcerated here throughout its 142-year history. But by the 1900s, the system of separation and isolation starts to fall away. The prison starts to reflect how prisons are today, and they're going to call that a congregate system. Here we have a photo of the prison's basketball team, because now the people incarcerated here are allowed to work together, eat together, and spend their recreation together as well. But another integral part of the history is the men and women who dedicated their lives to working here at Eastern State, and that is interpreted here as well. And the prison continues to be in operation until 1970. After that, it's going to enter a period of abandonment for roughly 20 years until the museum's going to open in 1994, and it will be open for tours daily. If you come to Eastern State today, you can have an audio tour narrated by actor and director Steve Buscemi, as well as hear firsthand accounts of the people that worked here and were incarcerated here as well. Another way to experience the site is through guided interpretation, either through one of our guide-led tours or one of our mini tours known as hands-on histories. But our interpretation isn't limited to the past. We also talk about what is happening right now in our criminal justice system. Through our big graph installation, we show what has happened to the rate of incarceration, which has rose over 600% since Eastern State closed in 1970. We take that a step further with our Prisons Today museum exhibit, where we ask our visitors to think critically about mass incarceration, possibly for the first time, right? And our attendance has continued to grow during these conversations. Our visitors, both returning and new, have welcomed and encouraged these new conversations surrounding these contemporary issues. And as we have these conversations, we're also asking ourselves, what can we do as a community to help those impacted by incarceration? So right now, we know that 1 out of 28 kids in America has a parent who's incarcerated. That's a kid in every class. Eastern State partners with local organizations to collect gifts for children with incarcerated parents. So now through December 22nd, any visitor can donate a new toy or children's book in its original packaging and receive a second admission free of charge. You're also more than welcome to just have presents sent straight to the prison, and we will donate them for you. Also happening this holiday season, you might have seen on your way in, we have started construction for our new visitor center. We are breaking ground, hoping to bring in climate control, modern restrooms, and a refillable water bottle station for everyone here. We're all very excited about that. If you're interested in learning how you can help support our programming, we have some lovely representatives from our membership team. Our members here help support events like Searchlight and events like Hidden Lives, which we did in the fall, and they help keep these events free to the public as well. Let's see. And speaking of Searchlight, what we're all here for tonight, please fill out the surveys that our team gave you on your way in. We value all of your input, and we definitely use it as we're making changes to our program. We will also be having a reception following tonight's talk by Capone Cell, which you passed on the way in. And next January, just for a sneak peek, we'll have Dr. Jason Williams coming in. His talk will be called Race as a Carceral Terrain, Black Lives Matter Meets Reentry, where he will be unpacking the criminalizing elements of race as a broader social control mechanism. But tonight, I am both honored to introduce Dr. Stephanie Fulmer as tonight's speaker. Dr. Stephanie Fulmer serves as the lead psychologist to the only female unit of a maximum security forensic hospital in the state of New Jersey. Her education and training focuses on specialized psychological assessments, which are used to assist the courts in determining how to best treat individuals who suffer from serious mental illness within the criminal justice system. Please join me in welcoming tonight's speaker, Dr. Stephanie Fulmer.
Hi, everyone. Thank you, Janae. I just have to figure out how to get back to my slideshow. Hold on one second. Okay. All right. I got it. You got it? Okay, great. Okay, great. Thank you. Thank you, everyone, for coming out. I know it's very chilly, very cold, so I appreciate it. I'm really excited to give this talk today, and if you do have any burning questions as I go along, just raise your hand. I'll try to spot you in the darkness, but there will be a question and answer section at the end. Okay, so today we're going to talk about how clinical psychology and forensics merge. And there's a lot of myths, I think, surrounding where in the criminal justice system psychology can play a role. So hopefully I help answer some of those. Okay, so what have you heard about forensic psychology? If you were here for a Criminal Minds episode, I'm not your person. You've come to the wrong spot. I also do not go out on the crime scenes and dig up evidence. I also do not look like this guy with 4 different computers around me trying to dig through random DNA files. I don't do any of those. I also don't do criminal profiling. It's much cooler. But what I do is something that I'll get into in a few slides from now. But I want to talk a little bit about what an inpatient is. On your, I guess, right or left, in the top left of see what basically is a picture that comes up if you Google inpatient psychiatric hospitals. It's actually from a Time magazine article depicting Pilgrim State Hospital, which is in Long Island. At this time, we have, it's in 1938, so you have Maryland, JFK, Sinatra, people being treated at this time. You have World War II veterans. You have the civil rights movement coming a little bit after. And then down on the far right is actually a really original, outdated picture of what Greystone Psychiatric Hospital is in upper state New Jersey. I do not work at this hospital, but the patients that I serve do sometimes go there. Okay, so what is forensic psychology? So a lot of people don't think this, the tarot card readings and everything, but it's actually a science There's assessments and tools that you use. And really, it, of course, like everything else, it comes from ancient Rome. There's a lot of different courts held, a lot of different mappings, and it's really the application of scientific principles and practices to the adversarial process where knowledgeable scientists play a role. So I'm going to talk more about that. So you have a legal question, right? You have what the court is trying to figure out, and then you have psychological knowledge. So you have people who are suffering from a mental illness. So in the where I would be or where somebody in my profession would be. Okay, so some questions that we're often asked is, why would somebody go to prison versus going to a psychiatric treatment facility? Oftentimes, this question is first presented by the lawyer, usually by a defense lawyer. The prosecutor's not trying to get the person help necessarily, although sometimes that's true too. If they have a past psychiatric history, so if they've have symptoms in an outpatient clinic, if they've been seen in the emergency room for symptoms that appear to be similar to what we know today, more so than depression, you're looking more at schizophrenia features, so psychosis, not making any sense, not able to follow conversations, erratic behavior. Those would be cause of concern. And then you also have individuals who have low cognitive abilities. So these individuals maybe just can't get their point across. They're not able to articulate what's going on, and they'll often be characterized in like a developmentally disabled community and are often sent to psychiatric hospitals. So here within the legal system is where it gets a little bit tricky. So everyone's heard, maybe some people have heard of the term not guilty by reason of insanity. This does not mean that the individual who committed a crime goes home. This does not mean that they are not responsible for what occurred. This does not mean even that they're not guilty, contrary to the definition. But what it means is that the person is believed to have been suffering from specific symptoms that made it difficult for them to know what was right or wrong according to the court of law at the time of the offense. So were there symptoms that were present that questioned someone's judgment enough that they didn't know that what they were doing was, quote, against the law? Then there's something separate. There's something called incompetent to stand trial. What that means is you have individuals who, at this current moment, are too sick or maybe have too low of cognitive abilities to understand what happens in the courtroom. They don't know what the judge does. They don't know who their attorney is. They can't interpret what a plea bargain would be or what a good decision would be to move forward. And in those cases, that person, according to our court system, cannot be tried. They cannot be tried if they don't know or understand what the possible charges are against them. It's against their amendment rights. Okay, so it's similar to thinking, you know, why you wouldn't have like a 4-year-old be tried in a court. They don't understand what's going on. Interesting, in my research for doing this presentation, so I work in New Jersey, but in Pennsylvania, guys do something very interesting where it's actually on the defense to prove that they did not know what they were doing at the time of the offense. So as opposed to, I guess, in New Jersey and most of the other states, it's, you know, the prosecution ends with, okay, can you prove this beyond a reasonable doubt? Really, the defense in Pennsylvania are the ones who have to prove this. So imagine an individual who has never been involved in the legal system before, gets, assigned a public defender who has 50 cases, has 2 minutes to talk to them, and is trying to assist them with what to do with their trial and their case. Notices that there's some mental health symptoms, but doesn't know how to proceed. So it's really quite tricky and a little bit surprising. I'm going to go back to this side. I'm going to talk a little bit more about forensic assessment versus clinical assessment. So in a clinical assessment, if I'm in a private practice, I'm looking at the individual, I'm trying to assess whether or not they have a diagnosis, whether or not they have symptoms, what's going on in their own experiences. So maybe what their family dynamics are like, how they're not going to work, how they're unable to get out of bed. It's focused on really assisting the patient, whereas in forensics, I see individuals all day, but they're not my client, right? They're not the person who I'm biased towards helping. I'm trying to gain information to see what is best to tell their attorney, to tell the court, to write a report, to paint a picture of who this person is without arguing a side. Okay? So, for example, here's how it's broken down into how a legal question is and how a psycholegal question is. So, if we go with risk of violence, I do violence risk assessments very often. So, what the question is, that the legal question is, what is the likelihood that the defendant will be violent in the future? So what, basically, if we let them out the door right now, what's the likelihood that they'll hurt somebody? For psychologists, my question is not just that one question, right? My question is, what have they done in the past? Where are they at mentally? What are their protective factors? Are they going back to family? Do they want to take medication? Do they find it to be beneficial? Do they have support around them? Are they going back to a job that they know? And that protective factors is one of the key elements in assessing where somebody might go and how much risk there poses to the community. Similar questions for competence to stand trial and for personal injury cases, which I won't touch on. So I see individuals right now for therapy, but I see them in a therapy context. Then I could be called on the stand to talk about not specifically what's discussed in therapy, but how I feel this individual might do. What do you think will happen to that relationship, right? That's going to be extremely, extremely challenging. So it's extremely tricky, the role that you have as a psychologist. Because as a therapist, you're there, you're one-on-one, there's confidentiality, you talk to me, we try to figure out a way for you to move forward and improve your daily functioning. Research, you do research in the field, you make sure you use all the citations, you gather all the data, you try to, explain to your audience what findings you have. As a professor, you have people around you, it's very clear cut. You grade, there's certain expectations on what the professor is supposed to provide. But in forensic psychology, there's that lack of bias, but that human emotion to want to connect to somebody, but having to keep yourself in check too. It can be extremely difficult, but there's also different roles too. Somebody who is a forensic consultant, so I could be hired by the defense or prosecuting attorney to assist them with questions they have, because a lot of attorneys don't understand all of the jargon and some of the language that's used in the forensic system. So it can be pretty difficult. I welcome questions on that later. So a little bit more on that too. A lot of times you're working with an attorney who really wants a specific outcome, and you're saying, hey, these are all these assessments. This is what the evidence is pointing towards. These are my recommendations. And they'll be like, but what's their diagnosis? It's like, well, I don't actually have one right now. My recommendation is this. And it's like, but what's their diagnosis? So it can be really difficult to remain non-judgmental and to follow your ethics as strongly as possible. And to really understand the patient's world as they see it, but to know who your client is, right? Your client is also the community. So my client is technically all of you. Talked about that. Talk a little bit about what I do during the day and how it relates to all of the issues that I discussed before. So when I go into work, I walk through 2 metal gates. I do not move when other patients are moving. I meet with them one-on-one. Usually there are specific medical security staff present. It all depends on your comfortability level, but I'm a core member of a treatment team. So when I go in, I get a morning report similar to a regular hospital. You hear about what happened the night before, how everyone's doing. And then as a social worker, psychiatrist, psychologist, art therapist, program coordinator, nurse, everyone goes out and sees an individual throughout the day. Then part of my afternoon will be individual therapy, group therapy, assessments, writing lots of notes, and of course, trying to supervise individuals who are interested in this as well. One other big key component is I run what's called a competency restoration program. So individuals who have a question of competency, so do they know what's going on at the time of the offense? Do they need help understanding, hey, you have a sentence of aggravated assault in the 2nd degree. That means 10 to 20 years. This is what would happen if you took a plea bargain. I run programs and groups to help individuals understand, to the best of their knowledge, that this is the picture. This is potentially what you're up against. And my hope is that more states can continue to do that. I came from Virginia, where they have a pretty good system, but not all states do that. And so unfortunately, people are left in inpatient hospitals for a very long time because there's not the resources available to ask difficult questions or to explain to them, hey, you go to trial next month, let's talk a little bit about what you're up against. Oh, I thought this was funny, so I included it. I'll read it for everyone. It says, we find the defense incompetent, the prosecution arrogant, the food inedible, the accommodations insufferable, and the defendant guilty as hell. Which would probably be quoting most of the patients that I work with. Although sometimes they tell me the food's good, so I don't know. It's really important to talk about cultural norms. When an individual comes in, they come in usually from a jail. They're usually what's called acting out in jail. They might be on suicide watch, and they come in and you're really not getting much out of them. You're asking them 100 million questions about where they grew up, and you're the 150th practitioner who asks them the same question. With that, you might get no eye contact, you might get opposition, you might get somebody very guarded, or you might get somebody very aggressive. It's so important to think about cultural differences and what generally certain trends are. For example, I had somebody who I worked with for 9 months who did not look at me, who had a diagnosis along the schizophrenia scale, and basically told me the last day that before I was leaving, gave me a piece of artwork and was then able to look at me. This individual was part of the Asian American population, where it's a sign of respect. But in all of their notes, it was, does not make eye contact, resistant to communication, resistant to wanting to engage. Is that true, or is that our normal and our expectations? And why is that a symptom, or is it? As we know, specifically physical proximity, we all live in a city where everyone likes to be nice and close and comfortable. I have patients who are intellectually disabled who will run up on me, and they just have no sense of space. It's not to be, assaultive or threatening. It's just, hi, I really want to kind of see you and talk to you. There's not that balance. And that just comes from a lack of cultural understanding, because they grew up in a family where everyone shared a bed and everyone lived with their 8 siblings. And there was none of that. There wasn't room for it, literally no room for it. We're very lucky where I work. We have interpreters, human interpreters and translators. One of my least favorite things is the language line. It's great. It's great that it exists, but it is extremely difficult. There are words that cannot be translated from English to other languages. There just aren't words for it. So that's been kind of interesting to learn a lot about. And of course, there's a lot of different religious practices that we need to be mindful of. So I am a very new entry-level professional. I work in a facility that houses, we have 9. There's 8 units or cell blocks. One of them is all female, and they are the most dangerous and quote-unquote dangerous. I'm using the term that you would hear. Sick and often institutionalized for the majority of their life in the state of New Jersey. It's the last stop. I often get asked if I'm the chaplain or if I'm going to help them with art. I also run groups with all of the gentlemen who are trying to get ready for court. They ask when my internship's up. It's really nice because I'm trying to keep that going for as long as I can. But it can be really challenging. A lot of the individuals I work with are much older than me. And I'm very mindful that I've lived in a different generation where I'm not only not going to know some of the references, but things just were as they were, right? And there wasn't really an explanation for that. Gender can be my best friend and not so much. Female unit, it took the women a while to get to like me. It's much easier to work with males, depending on where you're at, but it's usually much easier. And there's also different boundary issues, right? So you have people who are with officers who maybe they want to break down and they can't. They feel like they can't. maybe you remind them of somebody that they knew from their past, and that just you'll just never have a relationship with that person because you're trying to break down those walls. Just a little bit about that. Before I go to the next slide, it's kind of interesting because this is a little bit full circle. Do people know Muncie prison, the all-women's prison? Okay. I actually did a class there back, 8 years ago now. It was fascinating. There was 15 college students and 15 students, called them inside students. And before coming here, I reviewed some of my reflection papers, and I found something that I thought would be interesting to share. This is something that I wrote back in 2012. I said, at the end of the class, I had a curious and hopeful but concerned outlook on what to do about a system with institutional laws that seem so far beyond my control. And it's interesting because there was one women's unit here, and many of those women ended up in Muncie. So now a little full circle back around. And let's see. That is all that I have for you. Yeah. Thank you. Okay. Questions? Oh, am I taking questions? Oh, okay. Should I stand here?
Yeah.
Okay.
All right.
You know,
Does anyone have a question over here?
Just a quick question.
Yes.
Do you work with the juvenile population, or are they all adult women?
they're all adults.
Ah, okay.
Mm-hmm.
I was just curious.
Yes.
I had two. What is a protective factor?
Oh, great question. Something that an assessment, some psych assessments have been made to demonstrate what makes somebody less likely to commit a violent offense. Some of those things include education, strong family support, desire to seek treatment, things like that.
Thank you. And the other is, what is the best outcome and what is the likely outcome in these treatment cases? Like, do you treat them to competency and then they stand trial, or for things where it's not competency related? Or is there anything that's not competency related that you can't necessarily treat and they'll never stand trial?
Yes. Yes. That's a really good question. So a lot of times the prosecution will look to have somebody be found competent, right? So they'll stay in treatment for a lengthy amount of time, maybe 3 or 4 evaluations. So that could be up to a year, maybe over a year. Depending on the charges, sometimes the case will be dismissed, in which case they will serve their time in a forensic or psychiatric facility. So for some people, that's a best case scenario. For others, they'll be found competent a little quicker. They'll be able to also serve their time if they decide to take a not guilty by reason of insanity plea and serve their time, whatever it was going to be, not in prison, but in a psychiatric facility receiving treatment, right? Because the, quote, punishment should fit the crime. Thanks.
Do you ever encounter any malingering individuals or people who are faking it? And
Yes.
how do you tell the difference?
Yes, I am so glad that you mentioned that, because I actually skipped that slide because I was afraid I was going to run out of time. But now I can go back to it. Perfect. Thank you for that. So I do. I encounter people who only hear voices on Wednesdays, or somehow, that's a real question on the third measure at the bottom, actually, though. Don't tell anyone if they're trying to do that, though. But I do. So there's individuals who have been in the system for a while, and they know all the right things to say, and that's a very fun part of my job is, yes, is incarceration going up in the United States? 100%. However, there are individuals who have certain personality traits who cannot really be treated. They do not want to change. They inherently, at this point in their lives or their foreseeable future, we cannot provide psychological treatment for them. In this way, they're intent on trying to get the least possible sentence and to beat the court odds. There are assessments for this. One of them, the first one listed is, I'm just gonna go over this one, it's pretty simple. It's a picture, there's 50 pictures that somebody's shown, and basically the odds of somebody getting that right if they were guessing is 25%, right? If it's anything less than that, like 8%, somebody is actively trying to give you an incorrect question to an answer, they'll basically, that kind of rings a little bell for us, right? So if you show them a pen or a frog, and then you ask them, what did I just show you? And they're like, a frog. And you're like, no, not really. So there are certain things that we're able to do. And yeah, did that answer your question? Yeah. Yes.
How good is the research that's being done on screening people for release, and who's funding it?
Do you mean release into the community?
You mentioned that you assess people to see if they're going to be a risk after they're released.
Correct.
And I'm wondering, how good is the data on which you're basing it?
Right. So the psych measures that we use have really strong empirical evidence. They're used across the board in most of the states for any psychologists that work in an inpatient facility. These measures are continuing to improve. They've recently, for example, adopted a version specific to females and females factors that it was not part of the equation previously. Those measures actually come from other countries who are doing things better than us, if you ask me. And so a lot of them have been done, research comes from Canada, so we've adopted those measures. I guess who's funding them? It would depend. I guess it would depend on what facility you're working in. It would be state or federal, but there are private hospitals that utilize those measures because they're well known.
I want to see if I understand
Yes.
what it is you're doing. First, the idea of a person trying to escape punishment is a good thing, right? Well, come on.
Sure.
Yeah. So trying to escape punishment means that a lot of those criteria are rational behavior of somebody who doesn't want to be screwed.
Mm-hmm.
Okay, so your job is that you come upon people who have some serious and persistent mental illness. You meet with them, you try to do treatment, and you see them once a week, twice a week?
I could see them every day.
Every day? And for the other 23 hours, they're dropped back into a system that wants to punish them and is filled with people whose only issue is to keep them in their cells and keep them away from hurting people. It's a hospital with bars on the doors and windows. And if they get out of that, they deal with laws that are pretty bizarre. They deal with police who often lie to make arrests. They deal with prosecutors who overcharge to make their quota. Judges who are often, shall we say, racially biased, circa 1950. And who's crazy in this system?
I was going to say is that was a great closing. No. I mean, you bring up a lot of really good points. And to the first part, I would say that at least in the facility I'm at, the general idea in compared to a jail is that those people, I call them patients, right? They're not inmates. They're there for treatment. So when they are treated or found competent, you're absolutely right. They are going back to jail to do whatever time the justice system has decided. However, what I'm passionate about is, and what I hope and believe my colleagues are, is that there's at least the question of mental illness is at least being addressed and being followed up and being answered, so that maybe when this person leaves, so they have some medication that they wouldn't have otherwise had. They have more attorneys asking questions regarding competency, so you're not throwing somebody up there who has no idea what's going on and their rights are completely being violated. So do we have a long way to go? Are they being thrown back into the same system? Yes. Is this maybe a little beacon of hope? I like to think so. I honestly have not done as much extensive research as I would have liked in comparing the two. I've only ever worked in New Jersey, but I will say that one main factor is that New Jersey seems to be, quote, ahead in the sense that there are more attorneys asking those questions about competency. There are fully, I guess, 3 state psychiatric hospitals. The 4th is one that I work in, whereas in Pennsylvania, you have 2 and the closing of many. So in Pennsylvania, you have one on this side of the state and one all the way in Pittsburgh. So I would say they're ahead, if only by allowing services for treatment.
From the inmate/patient's perspective, how do they distinguish your role from a clinical psychologist versus a forensic psychologist?
Great question, thank you. I usually explain to them specific limits of confidentiality. So if I'm doing an assessment which involves their level of risk to either go to another hospital or go out to the community, I let them know that the report I'm writing is not confidential and that it's different than a regular client-therapist relationship, and that what they tell me will be placed in their chart and their treatment team will look at. Anybody in the court will have access to it. That's how I explain it to them. And then a forensic psychologist, is essentially, to them, I don't think there's too much of a difference, I would say. I just note that in therapy, there's a confidentiality, and when I'm doing a forensic assessment, it's not. It's, for lack of intensive purposes, my attempt at an unbiased assessment puzzle of who they are and how we can better assist them, or how their next provider can better assist them. Right. No, I'm glad you brought that up. Basically, so once their criminal charges are resolved, or even if they're not, so say, somebody has an aggravated arson charge and they're serving, quote, 5 years, but they have serious mental health issues, and what happens at that point is that individual will, quote, serve their 5 years in a psychiatric facility, potentially shorter. And then they'll be set up with services, as the probation seems fit, going from there. The jails do not have very, in my opinion, adequate or comprehensive mental health systems, which is why most people with any mental health systems are sent to a psychiatric facility, which is why the closing of so many of them is extremely difficult. Because then you have people who are missing who do end up in the jail systems, and there's one doctor for 3,000 people.
This is kind of a niche question, but it's just something that I've heard people say when they've worked with
Yes.
Assessments. Do you run into the issue of kind of religion walking the line of psychosis, for like walking that line of God is talking to me because I'm
Yeah.
religious versus because I'm hearing God actually speak to me? And how do you differentiate that?
That's a really good question. And I have this conversation with a lot of my colleagues, but as religion develops and as everyone kind of has their own way of practicing, I guess the best answer that I have for that is how much does it impact their daily functioning? So can they adaptively hold a job, take care of themselves, and still participate and follow the religion that they identify with? Is it causing them so much distress that they're unable to get out of bed, right? And the same goes along the continuum for anything such as, OCD, right? Everyone has some type of like compulsive activity or something that they like to do that's adaptive. But then there's a line where they can't leave the house for 3 hours because they're constantly checking the door. The same applies to religion, but it is much, much more complicated. Love to talk to you more about that. Sure. So they would. So in the groups, say if I'm running a group of 10 guys for competency restoration, I do not assess them for any court evaluation. Somebody else comes and assesses them. I simply would write a note that, we did a hypothetical scenario today, and Mr. Smith understood that he would talk to his defense attorney and not the prosecutor about his options, period. It's a good question. The individuals who, it's a really good question because the individuals that I tend to, and again, this is probably my bias, that I tend to work with in a more traditional therapeutic context are individuals who do not have legal charges. So they maybe are extremely self-injurious or have no desire to leave the hospital. We're trying to get them into other programming, but this has become their family. So, right, you bring up a really good point because then in order to keep things objective and not, I do tend to slide away from providing traditional therapeutic services so that I'm not biased when it comes to anything that could be put on paper. So it's a tricky role. Yeah. Yes.
Do you have a sense of the difference in how these issues are dealt with in other countries? You mentioned Canada, but compared to how we do it, and is there anything we can do to learn from that?
Yes, there's so much we can do. Well, Eastern State does a great job at, I think, educating, a lot of the individuals who come here and take tours are educated on, the differences in what type of violence we have per capita and how many people are institutionalized or incarcerated per capita, and how disproportional that is in the United States compared to other countries. I think that one very simple thing that we could do is having a database where records were able to be kept and transferred to other hospitals. I will wait months for a record of somebody from another hospital where it might give me a lot of information on somebody who knew them at that time, that I can then figure out, okay, what medication worked for them, what didn't, what part of their history was, oh wait, it's December 25th or 24th. Maybe they're just upset about the holidays. Oh no, their parent actually got in like a car crash. That would have been really helpful information for me to have. I think one thing that I know Canada does is they have a great online system that I guess professionals can access to give them information that, if used correctly, could benefit therapeutically.
This will be our last question.
Oh, I love questions.
I actually have two. The last two questions. So you mentioned cultural competency issues.
Yes.
Do you have any formal training in that, or
Yes.
were you just like thrown in and figured it out as you went along?
No, I would say I finished up residency a few years ago. I would say that my program specifically did a really good job at cultural competence. We had to write, we had to do our own presentation on our own biases. We had to constantly talk about what was coming up for us in our therapy, like in training. There's a specific portion of, I don't know, like the DS, basically like the psychology diagnostic manual on certain cultural issues that one should be sensitive to, and maybe quote like taboo topics. I think it also depends on the person. There's a lot of research to help us with that. But you have to be exposed to it too, right? So personally, yeah, I feel like I had a lot of really good training, as much as I could given this point.
Okay. Sorry. Second question, when someone is found not guilty by way of insanity, then are they just put in one of these psychiatric hospitals, or then what happens from there?
Usually they would then serve their time being treated in a psychiatric facility. So I'm working with a female now who is going through that process. And often the females that I see are serving murder charges. So in New Jersey, it's 30 to life. So they would spend 30 to life in a psychiatric facility as opposed to in a jail. Yes.
Thank you.
Yep. Thanks. Thank you.
Thank you, everyone, for coming, and thank you again, Dr. Stephanie Fulmer. Please meet us or feel free to join us at the reception down at Capone. Thank you, everyone.